Good morning, ladies and gentlemen. I think there are more speakers than the audience. Anyway, good morning and welcome to all of you to this Asia Pacific Strabismus and Pediatric Ophthalmology Society, Westmead Hospital, Sydney. I think I'm the scientific secretary. And this symposium usually is popular every year, but this time I find a little less crowd. Maybe let us see. We will have to make strabismus and pediatric ophthalmology more popular. We tried our best when we started. It was hardly 12 surgeons all over the country. Now I think there are more than 800. So for the population of ours, I think much more is needed. So I have great pleasure in introducing Dr. Deepa Tharanath. She's from Adelaide, and she has a 20 years practice in Australia and was trained by Professor Frank Martin. So we have a strong associate as co-chairman. I'm sorry that Sonal could not join. So with this brief introduction, let me call the first speaker, Dr. Sumita Agarkar, who is the Deputy Director of Pediatric Ophthalmology at Shankar Nethralaya, my right hand. She takes care of the department. Dr. Sumita Agarkar will speak on pediatric cataract, and it's not a child's game. Over to you.
Thank you, sir, for that kind introduction, and thank you for Asia Pacific Society to give me opportunity to speak in this session. So the theme of this session was the case I learned from, and this is just a regular day in the clinic. 14-month-old baby, parents complain that I've seen white reflex one eye since just 10 days. Visual acuity not cooperative for Taylor also, but briskly follows light and appears to have central steady fixation in both the eyes. He's orthophoric, there is no nystagmus, pupils appear okay. Anterior segment examination shows cataract in one eye, dense cataract in one eye. Fundus is within normal limits in the good eye, but there is no view in the affected eye. We do ultrasound and it looks okay. So anesthesia clearance is done, posted for surgery, and explained to the parents that IOL implantation to be decided on the table. Now, this is how it looks on the table with dilated. You can see that there is a little bit of pre-existing posterior capsular dehiscence with a little fishtail sign here, and which was not visible when we saw it in the OPD because people didn't dilate very well, but in the surgery after you have put dilatation, phenocaine and all, it's dilated. So I have to change my tactics a bit here, and after the usual staining, we are able to do, I aim for a slightly smaller axis because I don't know how large is the dehiscence behind. We do a little bit of hydrodelineation, not really a dissection. And in such cases where we have to anticipate a dehiscence, I start from peripheral aspiration of the cortex. And before I could aspirate, you can see that there is already a pre-existing and vitreous has prolapsed. But since I have gone with vitrectomy cannula for aspiration, I am able to complete the vitrectomy, regularize the edges of the PC, and the lens goes in the bag as anticipated. So again, another so IOL is implanted, surgery is given, glass is given, baby is doing well, we put him on patching, and I'm feeling great. Okay, I know how to, I have cracked this. A week later, a 3-year-old boy again presents with white reflex 5 days. History of blunt trauma, that's the only difference. That kid was very young and probably had a lenticonus with dehiscence, but this child has a blunt trauma. Visual acuity 6.9 and 0.5 with Leah symbols and hand movements in the left eye. Orthophoric, again anterior segment normal, or left eye is total cataract. Fundus is normal in the right eye, no view in the left eye, ultrasound normal, and this is, so I follow the same steps where you have to, so little bit confident ki I have done many and I know how to do it, and yes, this really beautifully takes up the stain, and the usual steps are same, like any other pediatric cataract. The smaller X's, luckily good stain, so I can visualize the capsule very nicely, and I am able to so air bubbles are also Murphy's law. When you don't want them, they will be there, and more you inject, more bubbles. Anyway, somehow I am able to grasp the flap and complete the Rexes. So Rex is a little bit larger than what I have anticipated or was planning for. But anyway, rest looks like a usual pre-existing dehiscence kind of thing. I have gone with a vitrector in aspiration mode, and my fluid flow, which should be lower, is a little on the higher side. There is, you can see there is a lot of turbulence, and before I can clear the whole cortex and a little bit of nucleus, and I'm now trying to hurry up quickly because my dehiscence has opened up already, and before I can catch it, it's gone. So I try to do a vitrectomy in order to float it up, but to no avail. There's nearly half of cortex which is there, and this little bit which is left here, I am aspirating it carefully, but you can see fair amount of cortex is behind, and there is a big spindle shaped rent there. So again, I thought, let me at least complete my thing here and see if I do vitrectomy, a little bit of if I can float the whole thing up by pushing the fluid. So I decide to go ahead and do the vitrectomy, but all that vitrectomy does is to push that bit really behind. So now I have to call a vitreoretinal colleague to come and help me out, and we do 3-plane pars plana vitrectomy. You can see there is a chunk, fair amount of chunk there, which I have to remove, and I was able to place the lens in the sulcus, and child ultimately did well. But lessons to learn here is that you should recognize lenticonus and PC dehiscence preoperatively. These are the signs: sudden onset of white reflex, bulge on the posterior lenticular surface if child is cooperative for slit lamp examination. A dense central cataract with relatively clear periphery is also indicative that there may be a dehiscence. And fishtail sign of cortical matter hanging around in the anterior vitreous cavity is almost pathognomic of PC dehiscence. ASOCT and B scan sometimes can identify dehiscence if you really carefully scan these children. In suspected dehiscence, you should aim for a smaller anterior capsulotomy, a careful hydrodissection, or rather only do a hydrodelineation to loosen up the cortex a bit, aspirate cortex from periphery, keeping all the fluidics low, so that vitreous prolapse happens after you have done the cortical cleanup rather than before. And use a vitrectomy probe to aspirate cortex rather than your bimanual cannula. And it is possible to convert dehiscence into a regular PPC and implant the IOL in the bag. Traumatic PC dehiscence can behave differently, the way I learned hard way, because vitreous is fluid in these patients, and in a congenital PC dehiscence, like in the other case, that cortical matter would have never gone down because vitreous is firm and formed. But in a case where there is history of trauma, probably it's best not to do any hydrodissection and keep a vitreoretinal colleague on the standby. And I should have put my fluid parameters much lower, aspiration flow rate and all, and we should not have done any hydrodissection, hydrodelineation at all in my second case. Thank you for the attention.
Just one comment. I think it's total cataracts, many times we don't see them as orthophoric. They'll have little extra foveal fixation if it's, especially if it is long standing. But I think
Yes.
your
So both
case,
these cases were just in 10 days and 15 days of noting the
what
white reflex.
I'm just giving them that
Yeah, and I think that
long standing unilateral cataracts, that they are densely amblyopia, and many times they don't improve at all with patching, and it will be suicidal to do patching of the good eye if there is a long standing cataract and do lensectomy. Your comments, please.
Sunita, do you have a preference of viscoelastic use?
I think my case
Viscoelastic, yeah, actually a lot of it in India, a lot of viscoelastic decisions are by what patient can opt for or pay for. But yes, in these cases, probably if you are planning to put in the presence of a large PC dehiscence like I had in the first case, I used a cohesive OVD like Hilonjivi for to make that PC really go back nicely, inflate the bag, and allows me very safely to put the lens in the bag.
No, that's true.
Yeah, but if you have already have a very large dehiscence, and like in the second case where I had no choice, probably you can get away with cellulose also. But
I
if
think
in the bag implantation, cohesive OVD is definitely very, very helpful.
Yeah, very true that, very true that I think what you said is right. Every pediatric cataract
Mike
is different. Every pediatric cataract is different, but also the choice of instruments and the viscoelastics that are available at the time, and even the implants, I think, make a difference, whether you're putting an implant in the bag or sulcus.
Yeah, 20 years back when we had only PMMA, it was impossible to put these lenses in the bag.
Yeah.
But I think now with foldable lenses have definitely been a game changer, and they really help us to. In fact, we published our data on posterior lenticonus and PC dehiscence, and out of 21 patients, we were able to put the lens in the bag in all 21.
That's
And if you look at an earlier publication from UK, there were a lot of lenses were in the sulcus.
Yeah.
Nothing to brag about me, but just the time.
Yeah.
We have much better access to much better machines, and
I mean, you guys do a lot of traumatic cataracts. So, in your experience, you said that the vitreous is liquid, more fluidy, and you're anticipating
especially
now.
in closed globe trauma. Sometimes.
Yeah, how long, in your experience, do you see these? Because you see a lot of trauma than we see in the Western world. So, do you think a month or more?
Yeah, I think more than that probably. Up to it's probably.
Because this case was 3 weeks post-trauma.
Yeah, he was 3 or 4 weeks post-trauma.
And it was quite liquid
by the time the white reflex developed, probably they are saying 3 weeks. So
Yeah,
it might have been longer.
Okay.
But he was orthophoric, so I believe parents' history that.
Thank you.
By the time actually your dehiscence may have happened at the time of injury, but for the fluid to leak and become cataractous, it takes maybe 4 weeks.
Yes.
3 to 4 weeks.
Yeah, usually they say about
Yeah, actually I should have anticipated in the second case, because the gap was too less, means probably
there has been a
there has been a more.
Great. Thanks. That was a great case with great learning points. Thank you so much. A big round of applause for Dr. Sumita Agarkar, please. The next speaker is Dr. NG-Vai Han from Singapore National Eye Center, Singapore. He's going to talk to us about a case of strabismus, unusual hypotropia, more than meets the eye. Thank you.
I think your name is pronounced as isn't it?
Yes, correct.
She told NG. So, Wei Yan. Right, that's
Sorry.
welcome.
Thanks for the kind invitation to speak. Let me see. Good morning, everyone. I'm Wei Yan from Singapore National Eye Center, and today I'll be speaking on a case of unusual hypotropia that's more than meets the eye. So, just a quick summary of the presentation. So, this patient is a 37-year-old Caucasian lady, and she's from Netherlands. So, she came in complaining of binocular oblique diplopia that was worse in the evening, and especially when she was tired. And she had a very specific complaint that she can actually describe, as where she describes it as the word is jumping, and she can localize it to the left eye as the problem eye, where she feels that especially when she's reading, she feels that the eye is jumping up and down in a vertical orientation. Otherwise, there's no prior history of a headache, trauma, and no ptosis as well. Right? And what makes matter worse is that this patient reads a lot, and her occupation is actually a lawyer. Right? Sorry. So, on clinical examination, initially, no matter how much we try to dissociate her, after quite a while of cover as well as alternate cover test, the patient still appeared autophoric. So at that point in time, we were wondering what's the actual cause for her issue with the jumping words. And she had actually, previous to this, already sought quite several opinions. So whether previous doctors wondered whether it was a thyroid eye disease causing some form of diplopia, but however, the thyroid function test was actually normal. And whether there was any intracranial pathology that could be associated as well. And they have done the MRI and it's actually normal. And finally, because of her complaints that actually is worse towards the end of the day and when she's tired, so the suspicion of ocular myasthenia. However, then the acetylcholine receptor antibody as well as the electrophysiological tests were all generally all normal as well. So when we spoke to the patient insists that the left eye is deviating, and she even had a documentary evidence. So, yes. So this is the photo this is the video that she actually showed with us, and actually showed that when she was, that she recorded at home, that the left eye was gradually drifting downwards occasionally, and she needs to blink to recover, especially when she is trying to focus for a long period of time. So on further examination, when we look at the fundus photo as well as the widescreen, so we can see that there's a slight excyclotorsion on the left side compared to the right eye. And on the widescreen, the left side has a bit of hypotropia, while the corresponding right eye has a bit of a hypertropia as well as excyclotorsion. So, despite that, so our general impression is actually still that of a right superior oblique palsy with right dominance, and she's actually mainly fixating the right eye, resulting in a manifestation of a left hypotropia. Right? And then we offered surgery, and our plan was actually inferior oblique recession. So then the patient was actually, it shocked the patient, right? So all the past few months, she was always looking at the left side as the problem eye, and yet we are telling her that actually the problem eye is the right eye, and we should be operating on her so-called normal eye. And therefore, she found it very difficult to accept, and whether as a lawyer, she would want a pristine outcome, right? So during that time, we offered, she can go back to her homeland or somewhere in Europe to get a second opinion. But sometimes, in life, that's when COVID happened, and then she was not able to travel back to her homeland. So in that sense, she was actually stuck in Singapore, and then further discussion and further review was performed so that we can discuss whether we just continue conservative management or whether to go for surgery. And over the months that we continued to review her, that's when we started to gradually find on prolonged dissociation that we see glimpses of a right hypertropia. As you can see on the primary gaze with the Spielman cover, you can see that there's a slight right hypertropia over there that's worse on left gaze. And on the head tilt, it's also slightly worse on the right head tilt as well, which ties in with the diagnosis of a right superior oblique palsy. Right? And that's when the patient eventually decided, okay, we'll go for the right inferior oblique surgery. And that's when we did the surgery, we did the recession to Park's point, 3 mm posterior and 2 mm lateral to the temporal border of inferior rectus. And so the patient's feedback. So initially the patient, of course, was very apprehensive because she was always thinking that the left eye is the problem eye, but we have suggested for the right eye. And so, but then she had faith in us, and we proceeded with surgery. Of course, early in the initial period, she had quite a bit of panic. Right? She didn't explicitly tell us this, but this was fed back to us later on. Right? So when she felt that everything was very dizzy, brought into focus, and she was still having some diplopia and feeling that she was in a warped world with a bizarre perception of depth. And it was only gradually, after that, about nearly coming to 2 weeks of surgery, that she, finally started to set in, and she felt comfortable, no more diplopia. And subsequently, 6 to 7 months after surgery, she was symptom-free, and then she was very glad that she actually went through the surgery by then. Right? So this post-operative, again, it was generally autophoric, and no real obvious limitation in extraocular movements. So our lessons learned for this was that even if it appears to be autophoric or autotropic, in primary position, patients might not be happy, especially we need to consider what the patient is actually complaining about. This patient is very educated and very aware. That's why we had video documentary evidence. But it's not every day that we can get such clear-cut evidence to convince us that there is really something wrong, right? And that sometimes strabismus surgery can be indicated even though it appears autophoric to us, right? And that we need to perform a complete orthoptic assessment, all 9 positions of gaze, as well as ancillary tests such as fundus photograph, as well as eye screening, so that we can actually elicit the true problem. Thank you.
Many times I think we do face orthophoria, and especially in children, bilateral superoblique palsy is present as an orthophoria in the primary gaze. But I think when you do the extraocular ductions and versions, I think you will find both the inferior obliques overacting. There's also another condition of masked superior oblique palsy. You may think that the tilt is to the right side and operate only the left eye, and you will be surprised to see the tilt goes to the opposite side. And you will be finding that the other superior oblique also is palsied. And oscillopsias sometimes, a sort of stroke, when it develops in old patients, they do develop such symptoms. But I think hypotropia is a little rather rare entity, and you have handled it well.
Thanks,
God
Prof.
bless. Congrats.
So just like to conclude with Prof that recently we also had one patient where a young patient about 7 years old, looked exactly like an XT with a fourth nerve palsy. So a lateral rectus recession and IO recession to Parkes point was done. It fulfilled all the Parkes 3-step tests. And immediately, within the next 3 days, it went to hypotropia. And the opposite, superior oblique palsy was unmasked, exactly as you said. So now parents are quite unhappy. The tilt is to the other side, and now we need to convince the parents that something needs to be done.
I've had another patient who had a very large tilt, and it was 4+ overaction superior oblique, but there was hypertropia, not like what you showed. So I did denervation and extirpation of the inferior oblique. That is nerve connecting to the inferior oblique. I simply cauterized and then buried the whole inferior oblique under the tenons. And the tilt from here to went to the other side. So it started having hypotropia. So I think recession has worked out very well. So the 1+, 2+, 3+, 4+, we have different options. I think recession works very well. I do a lot of myectomies. Yes.
Are there any questions? Please use the microphone.
So we did consider that, but because we felt that the etiology was still the right side, we tried to convince the patient that we'll still proceed to the right side. She was insistent on the left side initially, but over the months, we managed to gradually convince her from, instead of a left side inferior rectal surgery, to go ahead with the right side.
Very interesting case. Just want to maybe I missed it. Was there fundus torsion?
There was a slight left excicular torsion.
He showed in the diplopia charting also.
Yeah, one more comment. Given that this session is on lessons learned, the case I learned from, I think there was a lead in your history. Her hobby was horse riding, and I think that should ring a bell saying, is that what is making her aware of the problem? Because the position she uses, there are certain hobbies like playing snooker, billiards, or reading in bed, watching television, lying down in your couch, where the television is placed. So those are questions I would ask a patient, when they look orthophoric or orthotropic, and you're not able to get a good picture. I think spending that 2 extra minutes on what exactly, when do they notice this double vision, sometimes gives you the answer. Yeah, thank you.
Many times we also come across after the peribulbar block for the cataract surgery,
Yeah.
they also develop a little bit of hypo and hyper. So we try to manage mostly with the prisms. Now that so much Fresnel prisms are available in India, I think we are able to this thing. Otherwise, we do surgery.
I think there are a couple of other questions.
Yeah, one more.
You showed 9 days photographs. At that time, the 2 photos were missing, right tilt and left tilt. That would have given the diagnosis.
Fox 3-step.
We showed the 9 days, but
Yeah.
the tilt, right tilt, left tilt was not.
Actually, primary, there was no hyper. I think it was hypo. So, yeah, you are right. I think. Thank you.
Thank you. That would have brought it out, yes. So the next speaker is our esteemed chairperson, Dr. Surendran. He's going to give us a simple solution for a simple problem.
Change this thing. I think speaker is. So I have a different topic altogether. Simple problem for a simpler solution. Having done lots of strabismus surgeries, 40,000 and odd. So I thought I would not speak on these common topics of esotropia, exotropia, cyclotropia, all this. So I thought I will have a different topic altogether. So we come across a lot of simple solutions during our strabismus surgery. So I think we tried this about a couple of decades back when we were inventing a lot of gadgets for strabismus surgery. So as you know that strabismus surgery, first it involves how much is the deviation. You do a lot of first orthotic checkup, how many prisms, you counteract with again yourself the prisms after the orthoptist does it. But still a lot of measurements are there, and there can be misfiring of the measurements. So this needs to be checked, rechecked on the table in spite of calculation. So we need to do that. And what problem we faced about a couple of decades back. This was the vision of my assistant, who was a staff nurse, who could see like this. Can you guess why she was looking like this? Because the surgeon may use the microscope. The assistant sees like that. Nobody could guess. I think Abhinaya, who helped me in this project, she alone can guess it. It is presbyopia of the assistant. Presbyopic assistant was seeing like this. Okay? See how far she is taking the caliper. She is taking the caliper, she is doing some measurement and all. Ultimately, when I did the surgery that time, it was not all right. Suppose you are supposed to give 6 millimeters, you was giving 5 or 4. And again and again it was happening. So then I think my Abhinaya went through literature. She found that in Nigeria, I think it was the prevalence of presbyopes among the healthcare workers, especially the theater staff, is something like 40 to 71%. That was the problem. I also remember I did a camp in a place called Notrampalli, where I think I tested 5 people, all of them had presbyopia, and all were using the same glass. And so that is unfortunate. Now I think things are better. So prevalence is as high as 40 to 71% among the health care individuals. And this I think also is 35, 40 plus years of age if you are assistant. And close to 40% don't have other refractive correction. So this actually problem causes a productivity change, your outcome of the results, and the time consumption of the surgery gets prolonged, and you may have to repeat the surgery because if the calculation fails, you may have to repeat the surgery. So the dealing with measurements is very important, and for an accuracy check and to do how much of resection you do. This is actually mainly for resection of the muscles. Small and minute calibrations of the instrument is also responsible for this issue in seeing the print, what is seen in the calibrated clamps. So the transparent markings are there, 5, 10, 15, like that. So I thought what solution we can do. So initially the clamps were looking like that. So all I did was I just calibrated the clamp. You can see some fine markings there. Each millimeter put on vertical scale and then had an axis blade, and the markings were done, each one carrying 1 millimeter. So I didn't put 5, 10 and all. So you can easily measure 5 millimeters, 6 millimeters or 10 millimeters like that. So this was, I named it as calibrated resection clamp. But again, this was so huge. It was a pediatric eye, 1-year child you operate, and it will be just falling on one side, already the bulldog will be there on the other side, about to bite you. So what I thought was a simple add-on was made, and the multiple ridges page, this one is that original calibrated clamp. The multiple ridges spaced 1 millimeter apart close to the muzzle holding edge, and the vertical limbs of the clamps are noted very clearly with little magnified. So this actually was the final outcome what we designed, and I put it the calibrations on both sides of the clamp. So either lateral rectus, medial rectus, or right eye or left eye, medial and lateral rectus. So we put it on both sides, and the parts of the instrument you see here, and the calibrations are seen on both sides, and there's a lock there to lock the muzzle as you check for the resection, how much resection you do. Muzzle holding in, knob for locking the mechanism, and calibration. So this is a usual tray. I think that instrument also goes along with the Strabismus tray. So I am using a minified resection clamp. So you can see that 5 millimeters resection I have done. Exactly, it is showing 5 millimeters. So you don't require a nurse to give you the caliper. The clamp itself has a caliper and calibrated. So this is more precise and more accurate. And then finally we modified that clamp into a minified clamp. What you see in the bottom is a minified resection clamp, half of the size of the original clamps. And this minified clamps is just a little bigger than the bulldog, but it also has the same calibrations. So like this is only to people for you to innovate things. Actually, we did a small this thing also, a small plastic scale with so many numbers on it, plus and minus on both sides. Simply the scroll it account to do the retinoscopy. Like that, gadgets were designed, and especially you must have a good bioengineer to help you out. So the merits, it is easy to use, it is self-sufficient and saves a lot of time, easier for the surgeon and the ophthalmic assistant, but later that nurse had a presbyopic correction, that is different. Also clamps the muscle in the desired position, and chances of muscle slippage is lesser with this technique. Visibility of calibrations magnified, better and easier. When there are multiple solutions to a problem, choose the simplest one. Thank you. God bless you.
Thank
Bye-bye.
you. Thank you. I think that just shows that the more experienced you are, you've dealt with every problem, including as simple as presbyopia.
Yeah.
And I'm sure that many of us in the room might be presbyopic too, and that adds to the
No, I wanted
problems.
to innovate. They should innovate things. As you go to the theater, you keep saying what are the problems and keep innovating.
Are there any questions or comments from the floor? If not, I will do the next talk because I think it flows on well from your talk. So I'll do mine and then.
Is Kaushik there? Oh, yes, come.
I have to thank the All India Ophthalmological Society for inviting the Asia Pacific Society of Pediatric Ophthalmology and Strabismus. So thanks to the organizing committee and the scientific committee for giving us this session. Let's hope that in future we will have more attendance, but we always start small in pediatrics and squint. I think we've all learned it that way anyway. So basically, I'm going to talk to you about one of my patients. When Sonal asked me if I could speak on one of the cases, we learn from, I told her, we learn from every patient, so, which one do I choose? But then, I'm sure all of us have those difficult patients who have unexpected good outcomes as well as bad outcomes and leave an impact. And I think this man was the one I said, okay, I'm going to talk about. So Mr. JB, he's a 70-year-old retiree who presented with intermittent horizontal double vision. He had it for a few years, but it was sort of bothering him more and more lately, and so he decided he wanted to get something done because he's now, his wife passed away and he was more dependent on driving and other daily needs. His medical history involved hemochromatosis, which was being monitored. He didn't have any problems secondary to that, and hypertension, which was well controlled. Ocular history, he's not had any ocular surgery. He wears reading glasses usually. And I said, okay, fine. We went through the usual consenting process, and we decided we'll do a recess resect surgery on the left eye with adjustable sutures. His visual acuities, as you can see here, were normal 607.6. His reading glasses, when he showed us the reading glasses, we found out that he's wearing bifocals actually, and he was a known hyperope. We said, okay, this looks like a straightforward case. And the orthoptic measurements and eye movement assessment did show bilateral inferior oblique correction, and I said, look, we'll decide that as a second surgery because I had a trainee listed as well on the surgical list. Now, this was a final year registrar who said that they'd not done any resection on eye muscles. Unfortunately, in Australia, we don't get a lot of surgery in subspecialties, particularly squints. And I said, okay, well, this is your first one. And she was a potential trainee who I was hoping to lure her into doing pediatrics and strabismus. So I said, there's a good one for you. You'll do your first resection today. So I performed the resection first on a sliding nose adjustable suture, and then she just started working on the resection. And I was assisting when this suddenly happened. So this was the first view, but then I managed to get another camera phone and get a better view. Can you see what's happened? What's that? Yes. So the muscle had just snapped. I'd never seen this before. Or I'd seen it once, but that was a consecutive XT. So this man, mentally you're not prepared for a primary surgery to, end up with this. So we said, okay, we'll just stay calm. I explored the medial orbit. I did find the medial rectus stump, but it's so far back and fragile, I was not able to suture them back again. So I decided that I'll have to do a different surgery. And I said, why did this man's muscle break? There has to be something abnormal. Let's just take the stump. So about 11 millimeter of the tendon and the anterior stump of the muscle, I excised and sent in formalin for histopath. And then I did a Hammersheim type partial transposition. That was the plan. So I took the inferior half of the left inferior rectus and transposed it to the inferior end of the medial rectus. And I tried to spare the anterior ciliary vessels. And that went fine, as you can see. So I proceeded to do the superior one. But because there was an anterior ciliary vessel that was quite right on the middle of the muscle, I decided to do just the medial third of the superior rectus. Isolated it, everything fine, till that happened again. So when I put the suture, pre-placed the suture, and had just not even cut the muscle in front of it, you can see that's the piece here. This is the tendon as well as the bit of superior rectus that snapped. So here we go again. What do we do now? Can't do anything now. You lost your second option. So I said, okay, fine. We'll probably just have to call it the day and finished it. And basically, as some of you identified, it's pulled-into syndrome. And I believe those of you who have been in the subspecialty for, I think one of the survey papers from Ellis and David Garnett's group in 2016, they published, they said if you've done 10 years of strabismus surgery, you'll see at least one of these. So count the number of years you've worked. I'm sure there's one coming your way if you're celebrating your 10th anniversary at work. So I sent it for histology, and I wondered if hemochromatosis had anything to do with it, because that was his starting medical history. And it didn't show anything other than variable muscle size, fibrous tissue, which was a bit more than usual. So they did various stains, again, just fibrous tissue, more than usual. And they did even inflammatory immunohistochemistry, so it was not an inflammatory inflamed muscle. So literature evidence, there is one paper which has looked at histology of these pulled-into muscles. And interestingly, all of them have some degree of fibrous tissue hyperplasia and muscle atrophy. These are all old patients. So when we say old or elderly, that's where the definition comes. So the survey paper of 2016 looked at the number of, they said the risk is more in over 50s and more so if over 70s. So, I'll leave it to you as to who you want to say, call as elderly. But this is something that I never had experienced before, so I thought it's something I should share with. So this is Mr. JB post-op. He looks pretty much similar to what he was pre-op, and his symptoms were much the same. He, in fact, because I had to do the open disclosure of what happened in the surgery and why I gave up after the second muscle snapped. And he said, look, you've given it your best shot, so that's all we can do in life. And I know I gave it my best shot, which I think was the biggest lesson I learned. Because he didn't go home, worse than what he came, because mentally he was accepting that. And I think that's the biggest lesson I learned from this patient. And you can see that his adduction is not too bad, even with that half of medial rectus that was half of inferior rectus that was transposed medially. He still had, reasonable degree of adduction, so he's continuing to do everything except that he's not driving anymore, which is sad. So listing out the risk factors, as I mentioned earlier, age is now supposed to be a risk factor for PITS, even if you don't have any underlying ocular or systemic risk factors. Cases who have had previous surgery, previous Botox injections, or are high myopes with or without having had retinal detachment surgery, any cause of restrictive strabismus, congenital fibrosis of extraocular muscles, thyroid eye disease, amyloidosis, all these have been listed. So these are listed cases of known PITS syndrome, but the most striking thing was the age factor, because I think most of our patients don't have any of these underlying, factors, and it could be just someone who you think as being normal. So medial, and when I went and did more literature search, I found some facts and I thought I should share with you. I believe medial rectus is the most commonly lost muscle because it doesn't have any facial attachments to the oblique muscles, makes sense. And it recoils back easily through the Tenon's capsule, because I believe the muscle sheath of medial rectus is quite thick compared to others, so it just slips through the tube. And very often, you have slip muscle cases that you see post-esotropia surgery, similar sort of a background. I couldn't find any literature evidence on PITS in superior, it should be superior rectus muscle. There's one case where they had found the same thing. Superior rectus, for some reason, breaks from the tendon, not just in the muscle. So I don't know what's the difference in anatomy. I haven't dug into it that far, but there may be something different in the collagen. Intraoperative tips. Deepening the anesthesia helps because that avoids the muscle from being contracted and sort of retracted back in position. And I think we need to warn the anesthetist to not give any atropine because an oculocardiac reflex may help you actually find the muscle stump when you're trying to touch the tissues in a bloody field. Using high magnification, I use loops, but you could just transfer to an operating microscope and increase the magnification, and avoid digging in areas that you're not seeing properly, because that could lead to fat adherence and even worse problems. Literature also shows that 70% of cases muscles were found and reattached. They've also done marginal myotomy, and I'm just wondering, if this was a lateral rectus muscle, maybe it might be a bit easier, but medial rectus, I think the access might be quite a tricky one. Not that something I've seen for other reasons anyway. So transposition surgery was the most common one preferred in the survey. 50% people offered that, and the rest of them didn't do anything. Once they had the PITS, they just left the patient as is and had a disclosure. So my lesson, one of the lessons learned was include PITS in any squint surgery in adults, whether there is underlying known ocular factor or not, just so that medico-legally we are covered for any outcomes, because a man who's living single, I've had to now take him off his driving license. There may be other implications, if he was working and whatnot. So that's something I've now included in my consenting process, is to have PITS included. And obviously the other lessons I've shared with you, saying patients are forgiving and they do know that you've given your best shot. Thank you. I also take this opportunity for those of you who have not become members of the Asia Pacific Society of Pediatric Ophthalmology and Squint, please consider becoming a member. That will help us improve the attendance in sessions and share our experiences. So please contact Sonal or any of us who are members. And lastly, the Asia Pacific ASPS meeting of 2025 is going to be in Brisbane. This is going to be a joint meeting with our National Squint Society meeting and the Pediatric Ophthalmology Society. So yeah, I believe it's going to be a 2 to 3 day program, and I'm sure that I'll see most of you, if not all of you, at the meeting. Thank you. Any questions, any comments?
No.
I left it there, and I did see what he looked like post-op, but I didn't move the muscle. I left it at where it was. No, I didn't do anything because he did have a bit of adduction, and I was like, okay, he's got something there. I don't want to do, any more. And so I left it at 10. I thought 10 was a bit, on the higher side anyway. Yes, and that's something I spoke to him afterwards, saying, we may have, because he had some degree of, he had minus one adduction deficit on the left. So I could have easily done a bit more on the other right eye, but he said, look, I'm happy. I've been like this most of my life. I just thought I should give it a go. And given that the muscle braked and there was no underlying cause, I was hesitant as well, because what if the same thing happens when I'm operating on the other eye? Because he's not someone where we have a known cause that he's CFEOM or, we don't know what's abnormal with the muscle. So I was not very keen to, yeah. Thank you.
Yeah, I think that was a very wonderful presentation. So I just wanted to share my experience. So I have had kids, patients with non-marking Strabismus cases.
Yeah.
So,
Okay.
we know that as the age increases and the other systemic risk factors like diabetes, hypertension, these issues, intermuscular septicity into a lot of degenerative changes, right? And then, as you said, histopathology, the muscle becomes fibrotic. So they are very prone to building. They are extremely tight. So in my case, the rear rectus was extremely tight, and it doesn't give you time to understand how it happens. So you have to be extremely clear, secure as early as possible in the rectus, so that you would still avoid this. And being the isotropia, hypertropia was very severe in my case, so I was reluctant to. I couldn't retrieve the muscle. But as you said, there was no much change, because in my case, despite the pooling and lost rear rectus, next day the alignment was not of very much change. Other than like whatever the input that I got for the part itself of the sun.
It's almost like you did the treatment that they say disinsert
Yes,
the muscle.
And this was even if it has gone, probably I wanted to deepen the MR. We lost the MR. So whatever effect I got, that was in addition to what we did in my case.
Thank you for sharing your experience.
Just,
How many of you have seen PITS? Just in
I have seen one last 8 years.
1, 2, 3, 4, 5. Yes. Yeah. Same. I've seen 2 in 20. One was the first one that I assisted one of my mentors for a consecutive XT in an adult, and that was my first one, and this is my second. Coming back to my registrar, I should tell you of what happened to the registrar. She was so petrified, never wanted to do another resection or any squint surgery. I think I have, yeah. So another lesson learned was maybe if you want to lure your registrars and trainees into doing pediatrics or squint, maybe not adult strabismus to start with, do with the pediatric muscles. I think they're much more easier and forgiving than adults.
And actually, my case was in a pediatric case, ma'am.
Okay.
I was trying to do a bimetal resection in a case of dysotropia. One eye it went smooth, there is no problem, but the other I don't know why it happened. So somehow, just because a small tag was there left, so somehow I could pull
You
it
could
back
pull it
and
back.
guide it. So that saved my day, I guess. And after that,
But that would be a slipped muscle rather than a pulled in two. Pulled in two is it's the muscle belly has both
it breaks, but there's a very thin tag line still attached to the stem. That's how I was very carefully and slowly put the whole muscle again. And somehow
You were lucky. You were lucky.
Very lucky.
Or the patient was lucky. I think both. Yes, both. No, thank you.
Yeah, Dr. Qureshi.
Yeah, I just want to ask, how much time would you spend on a slip, not a fix, but if you got a slip muscle and it's fallen back in, would you spend an hour, 2 hours, 3 hours trying to get the muscle back, or would you abandon? What is the...
I think time is, in my case, I would not keep time as the factor. It's probably, the field of your vision and what you're seeing there. Making the decision is much quicker once you see or you don't see, right? And if I don't see, well, we've made the decision there. And if you've seen, you've made a decision whether you're transposing. But if I'm going to do a transposition, I had to tell the anesthetist I'll need an hour extra. But because of the pulled in two, we were very slow, and this man ended up from a 1 hour surgery to a 2.5 hour surgery. So we do remember this case because some other case had to be cancelled, the implications of running over. But for your question, as I think, yeah, you'll have to make a decision, yes or no. You're seeing it or you're not seeing it. That's how I look at it, yeah.
I have been very fortunate that I think having done more than 60,000 muscles, I lost only once. That too was a doctor. So he was a surgeon. And I think those days I used to have this Berkeley engineering from California, Berkeley. They had an instrument EMG machine. So I just, I think, went towards the conjunctival side and went on, and then was using this gadget. And the tip of that gadget, it has the tungsten needle, and at the tip of the gadget, the moment the muzzle touches the thing, that needle, you get a honk. So there I got it, and then I pulled it, and the surgeon is back for surgery. Now he has undergone cataract surgery. Initially it was intermittent squint.
Was the
but
surgery under local or general?
it was under local.
Local, yeah.
He
Because
came
if
as
it's general
an
anesthetic, you're not allowed to use the
adult.
EMG. Yeah.
But I used only once, and luckily only once it has happened. And this adjustable sutures, actually what we see the next day, I got trained by Alan Scott and also Jampolsky, but I think their hands, I thought it was working. Even Americans, 50% do adjustable sutures. But the problem is that one patient I did way back in 80s, and I think I had an oculocardiac reflex in the outpatient clinic itself, the moment I was trying to adjust. So I think I gave it off. Another thing is the next day what you see, and then after 6 weeks what you see. What you see as a residual ESO, when you adjust, I think it may invariably lands up later with something else. And what you see is on orthophoric next day, it invariably. And many times, whenever I decide to do the adjustable sutures, especially after buckling surgeries, etc., where there were, I think, the post-operative results which is not predicted. So whenever I did that, it was orthophory. I tried to put an adjustable suture and kept it for the next day, but it was orthophory. Simply put the knot, but very, very little experience I have. I gave it up. Now I adjusted myself not to do any adjustment. I never lost a muscle, and also if I do a free tenotomy for certain cases like myopathies, etc., what I do is I put an anchor suture. I think any adjustable suture like that, you put an anchor suture around 12 to 14 millimeters, just about maybe 3/4 of an inch of Vicryl 60 suture. Leave it there with a loose hold. Suppose I think you miss the muzzle, you can pick that suture and the muzzle will be intact. This is just an idea. I have done that in many cases. Luckily, I never lost, or it never went in for consecutive EXO or ESO. So, but this one suggestion, any adjustable suture if they want to do, you can put an anchor suture 10 millimeters away and bury it inside. Let it get buried. It won't cause it. Maybe an implantation, cyst may happen once in a way. That also very rare. Thank you very much. for
Thank
that
you for sharing your pearls.
Excellent.
I
presentation.
invite. The last speaker of the session, Dr. Kaushik Murli from Shankara Eye Hospital in Bengaluru. He's going to talk to us about a hyperactive child with an improper gait and a visual jumble. Look forward to it. Thank you.
Thank you so much, ma'am. Again, grateful to APSPOS and AIOC for making me part of this session. I would like to acknowledge my colleagues Aditya Goyal and Nikita who helped me put together this presentation and show what we had to see. So typically as those of us who see squints, this is part of our day job. We look for turns, we look for tilts, we look to see whether the chin is up, whether the chin is down, and that's something that we do very routinely. But when you talk of somebody walking or gait, what does it even mean? Today, most of us have specialized in ophthalmology, subspecialized. We're talking of decades of experience in the subspecialty that we forget some of the simpler things. So when you look at how gait is defined, it is defined as a method of locomotion using reciprocal placement of the lower limbs for both propulsion and support. So that makes it very important that gait is not just to get from point A to point B, but also to support a person. So this is a typical child that walked into our clinic for a review. He was wearing glasses. He was a 7-year-old who was accompanied by his mother with complaints of repetitive blinking and that he would look at the corner of his eye, and this is a kid who is just randomly jumping around. He had a birth weight of 3.1 kg, C-section. He had delayed speech. Mother said he was extremely careless and would trip and fall. And the child went to a regular school. He was well aware of numbers, alphabets, colors, and shapes, which was kind of okay for his age. When we recorded his visual acuity, he was wearing a glass with about a 0.5 diopter spherical, and we recorded a vision of 6.6 for distance and N6 at about 35 centimeters. Retinoscopy showed a little bit more of minus, and when we did a cyclo and then an acceptance, we saw that with -1 diopters, he was reading 6.6 and N6. When I did a cover test, unfortunately, I don't have a video of this, the child showed a little bit of an esophoria with his present glasses. Slit lamp exam was perfectly okay, fundus was okay. And I had actually visited a friend's clinic where I saw this child who was walking on a tiptoes, and the minute he put yoke prisms, apologize that the image is a little blurry, the child was immediately able to plant their feet on the ground. So that kind of got me curious, saying, okay, have I really looked at how this child is walking in? And then when you look at this child when they're walking in, the length is slightly reduced, the width between them, so they seem to be kind of walking on two sides. And if you look at even the way his hips are, they're kind of flexed out. And they take a little bit of time in terms of changing their stance. So when they're moving from one step to the other, that's what we noticed was happening. We then got his binocular vision assessment done. Again, sorry, the video is not playing. But yeah, so we noticed his fixation was okay. Saccades, his saccades and pursuits showed poor ability and accuracy, and then his extraocular movements were okay. MEM showed a little bit of a plus. We were not able to do any visual perceptual skills test. We then sent him to a developmental pediatrician because one, we thought his gait was kind of a little off. We had read some literature that we thought it was. And then the child was diagnosed to be an autism spectrum disorder. So what lessons we had learned from a little bit of what I had visited my friend and what I saw in this child is that the gait is very important when the child walks in. And that kind of gives you a clue as to how their balance is, what they're doing, how they're kind of managing their environment, their overall spatial environment. That gives us a huge, huge clue. Even when we're doing a cover test, typically we tell the child to sit down, we plonk a target, and then we start the cover test. The way they slouch can even give you an idea as to whether they're myopic or hyperopic. So a typical myopic child would have a little rounded shoulders with the scapula kind of pulled in, then they would kind of bend down. And that kind of a posture you will typically see, and the tail is kind of tucked in. So you see the child with the tail tucked in with slouching, probably they're myopic. And that kind of gave us a clue again in this child with that esophoria, saying that maybe he was slightly undercorrected as a myopia. There have been some published literature. A lot of these are very, very old literature that looked at behavioral optics. A lot of these images, we found it circulating on WhatsApp, and some of it we couldn't even figure out references for this. I did try a Google image search. But again, looking at the way a person stands can give you some idea of what you would typically find in your exam. And these are things that now we've started finding very useful in terms of estimating in children who are hyperactive, in terms of whether we are appropriately correcting them. Because once you see them back on review, if you see that the posture has got a little better, whether the hip is in front of their back or whether it's in front of the abdominal line, that kind of tells us whether we need to undercorrect or overcorrect them, and that enables us to further figure out what has to be done. So typically this is how that line is supposed to be. It is supposed to kind of intersect the auditory meatus, the acromion of the shoulders, the acetabulum of the pelvis bone, and the center of the axon. So that's a perfectly straight thing. So anybody who's got their head in front of this line is likely to have a reduction in accommodation. Anybody with a lead with the chin coming in front, possibly they are myopic. So what we look for cues again in these children who are myopic or hyperactive is that they have a very narrow focus. They're very focused on what they want to do or what they want to see. If they kind of are looking at your fixation strip and you want to suddenly switch, it may take a little bit longer time. Again, their posture in terms of lordosis, whether they have their knees away, helps us. Uncorrected myopia does exhibit esophoria, and they have a difficulty in terms of perceiving their entire spatial context. So this again is very, very critical for us to understand that the clinic doesn't overwhelm them. The furniture that you keep, the pictures that you put on your wall, all of these could kind of overwhelm these children. They do have a weakened core musculature, and typically you would see them kind of tiptoe. So it's as though they're climbing a hill is what you would see them walk. This child then underwent vision therapy subsequently, and we were able to enhance most of his perceptual attributes. His fixation got better, saccades pursuits got better. The esophoria did continue a little bit, but the child did develop fusion, and we were able to do a perceptual assessment that showed that he was a little lagging for his age. What did we learn from this is, as pediatric ophthalmologists, the minute we see a squint, we kind of trying to break our head as to what the diagnosis is and what we should do. Should we look at prisms, glasses, surgery? So multiple thoughts come into play. We're extremely worried, saying that am I missing a vertical, am I missing something else? But it is very, very important for us to examine the child as a whole. It is very important that you start observing the child as they're walking into your clinic, because that itself can give you a lot of cue. Again, another lesson that we've learned sometimes is that diagnosing a child with autism spectrum is different from branding a child as autism spectrum. Today, there is a tendency for every hyperactive child to be called autistic. We should be very, very careful about it. And not every child with autism needs to be hyperactive either. So looking at some of these other cues of whether you see some esophoria, whether you see some postural variation, whether you see any spatial discomfort that the child is going through, can help you kind of guide them to go to a developmental pediatrician, not a routine pediatrician. Again, you have to be a little cautious there. Again, these are some lessons that we learned even with this child. He was seeing a regular pediatrician. We're not picked up the fact that he had a spectrum illness. And again, as ophthalmologists, we are very kicked about the visual acuity chart. We want all our patients, if we operate cataract, to read 6/6. If we have given glasses, we want them to be 6, 6, and 6. But I think we need to remember the very old adage that the eye leads the body, and the vision goes much beyond that into movements, gait, posture, and behavior. And what we have seen working with children with spectrum is that vision therapy and training does to a very large extent improve behavior. We may not have clear answers in terms of the actual method with which it helps, but it does definitely help. Once again, thank you so much for having me as a part of this session.
Thank you. Are there any questions or comments from the floor?
Can I?
Yes?
So I'm an oculoplastic surgeon, but I can probably claim myself to be a strabismologist. I induce a lot of strabismus, doing orbital decompressions, doing fracture work and all this stuff. The quick questions and comments about each one of them. Dr. Surendran highlighted the role of presbyopia and allied healthcare workers. And he rightly pointed out, as the surgeons evolve from 20s to 30s to 40s to 50s, there's a barrier to have presbyopic correction. One of the tips he taught me was, when I was going through the phase, just accept it and wear your glasses. And I think there's a natural barrier for us all to do that. And I, as an oculoplastic surgeon, I'm doing punctal dilatation. That was my first tip off that I'm not there anymore. So thank you for the pearl. The second question was for you, actually. she talked about rupturing a muscle. And every single time I give a child for enucleation to my resident or my fellow, I dread that muscle rupturing, the way they're yanking the eye. So I was wondering, the Pitt syndrome, how much of it is a surgeon factor on top of the other factors that you talked about?
Yeah, and that's why I highlighted the fact that, she actually was the primary surgeon and I was the assistant. So obviously, if she was my assistant, that's what I would have blamed, saying maybe she yanked it too much. So in my case, I was the assistant. And I don't think I'll take the blame after doing so many surgeries.
But when you put the muscle back after the pits, we know that the function is not the same.
Yes, that's
For example, when I do fracture dissection, inferior oblique disinsertion for a combined flow medial wall fracture, sometimes I consciously disinsert the inferior oblique. But a novice will actually not disinsert from the periosteum, but actually transects the inferior oblique. And we know when you put it back, the torsional diplopia is almost impossible to manage. And the patients go through a lot. So the logic behind just reattaching the muscles.
Yeah, I think reattaching the muscles will have a lesser such impact than actually, getting through the muscle belly, because that's where the function of the muscle is. The strength of the muscle is in the belly. Disinserting at the tendon, that's what we all do with squint surgeries. I don't think that has, that's not, we are using the impact in a favorable way to, relieve the patient of what the problem they have. But PITS it breaks in the belly of the muscle, and I think even if you sew it up together, it's never going to work the same.
But that's what you recommend, right?
That's what the literature, the survey results are, that 45% patients had resuturing of the muscle. They could have resutured. If that was the question, were you able to resuture the muscle, they might have answered yes. But what happens after that, is for the next set of strabismologists in the department to put a paper out. Yeah. Thank you again, and it's been a pleasure to have you all. Hope to see you next time, and I think the next session people are here, so thank you all.